Imagine a stroke so precise, so like surgically exact, that it literally splits your body's pain receptors right down the middle.
Oh, wow. Yeah.
Right, like your face goes completely numb on the left side, but your body loses all feeling on the right.
It just sounds like science fiction. Or, I don't know, an impossible glitch in the Matrix.
Yeah, exactly. But it actually happens. So today, we are opening up this really fascinating set of clinical neurology data to map out the back of the human brain, specifically what neurologists call the posterior circulation.
Which is such a complex area.
It is. We're talking about the blood supply and, the microscopic, tightly packed wiring of the brainstem and the cerebellum. And look, if you're listening to this deep dive right now and thinking, wait, I'm not a neurosurgeon, this is going to be way over my head, I promise you it won't be.
Right. It definitely has this reputation for being hopelessly confusing. I mean, even to medical students.
Oh, for sure. But today, we're going to decode it together. Okay, let's unpack this.
And, that's the perfect mindset to have, because this really isn't about memorizing a dense medical textbook. It's about understanding the brain as this incredibly precise, deeply logical topographical map.
A map where structure dictates absolutely everything.
Exactly. In this part of the body, structure is everything.
Okay, so to understand the brainstem, I mean, we have to start by understanding the basic plumbing, right? The blood vessels.
Right, the power grid.
Yeah. So we're beginning our map by looking at the three main arteries that feed the cerebellum, which is your brain's main balance center at the very back of your head.
And right here is where we hit the golden rule for this entire deep dive. Start with structure, not names.
Which is so important.
It really is, because if you try to just memorize, lists of symptoms attached to random medical names, you are instantly going to get lost.
Right.
But if you know exactly what function a specific artery fuels, well, you know exactly what breaks down when that specific artery is blocked. It's just pure cause and effect.
So we aren't just reciting symptoms here.
Right.
We're looking at the mechanics.
Exactly.
Let's look at the first of those three arteries, which is PICA. That stands for the posterior inferior cerebellar artery.
PICA, right.
Yeah, and our data breaks this down beautifully based on exactly where the blockage happens. It says if the medial branch of PICA is affected, it involves areas called the vermis and the vestibulocerebellum.
Which is a mouthful.
It really is.
Okay.
And that results in prominent vertigo, ataxia, and nystagmus. But, I mean, what are those structures actually doing?
Well, let's break those down. So the vermis, it literally means worm in Latin.
Okay, kind of gross, but okay.
Right. It's this narrow worm-like band of tissue right in the midline of the cerebellum. And its primary job is managing your central core posture against gravity.
So just keeping you upright.
Basically, yeah. And the vestibulocerebellum works right alongside it, processing your inner ear's balance signals. So if a clot blocks the medial branch of PICA, those specific areas just starve of oxygen.
And the mechanical result of that.
Vertigo, which is that intense spinning sensation. Ataxia, meaning a total loss of physical coordination. Like you literally cannot sit up straight.
Wow.
Yeah. And nystagmus, which are these rapid, involuntary, jerking eye movements, because your brain is basically desperately trying to figure out which way is up.
Okay, so the core mechanics of balance just completely go offline. But what if the blockage hits the lateral branch of PICA instead, like the outer part of the hemisphere?
Well, then the picture expands. The outer hemispheres of the cerebellum, they control the limbs rather than just the core.
Oh, I see.
So you still get the vertigo, but you add gait ataxia, which is like a drunken stumbling walk.
Got it.
You also get limb dysmetria, which is this really fascinating mechanical failure. It means you overshoot or undershoot when you try to reach for something.
So your brain just loses its internal measuring tape.
That's a perfect way to put it. You also see profound nausea, vomiting, and gaze palsies, meaning the eyes can't move together in certain directions.
Right. And there is a massive structural trap here that we absolutely cannot ignore. Large PCA infarcts or strokes are a literal neurosurgical emergency.
Yes, a massive emergency.
Because when that cerebellar tissue gets damaged, it naturally swells.
Right.
And because the cerebellum is packed so tightly into the back of the skull, right next to the brainstem, I mean, that swelling has nowhere to go.
Precisely. That swelling creates a fatal bottleneck.
Right.
It can cause obstructive hydrocephalus, which basically means it physically pinches shut the canals that drain your spinal fluid, so it traps that fluid inside the brain and skyrockets the pressure.
It's terrifying.
It gets worse. The swollen cerebellum can actually physically push forward and crush the brainstem itself. It's a catastrophic structural crisis that requires immediate surgical decompression.
Wow. Okay, so PCA handles the brute mechanics of core balance and limb coordination. But spatial awareness isn't just about gravity and movement, right? I mean, it's integrated with your hearing and facial senses.
Right.
So how does the brain power that integration?
Well, that's where the second artery comes in, AICA, the anterior inferior cerebellar artery.
Okay.
When this artery is blocked, it produces a ventral cerebellar infarction. You still get the vertigo and nausea because it hits the vestibular nuclei. Those are the balance relay stations. But AICA feeds a slightly higher neighborhood,
Right.
an area called the pontomedullary tegmentum.
Okay, hold on. Pontomedullary tegmentum.
Yep.
We are definitely going to need a translation for that one.
Yeah, fair enough. It really just refers to the covering the tegmentum of the junction where the pons meets the medulla in the brainstem.
Okay.
Just think of it as a highly congested intersection where several major sensory highways converge. And one of those highways is the trigeminal system.
Which is the nerve system for the face, right?
Exactly. The trigeminal nerve carries touch, pain, and temperature sensation from your face straight into the brain. Because AICA supplies the blood to that specific junction, a blockage means that sensory highway loses power.
So what happens to the patient?
The mechanical result is ipsilateral facial numbness. And ipsilateral just means on the same side as the stroke.
So if the left AICA is blocked, the left side of your face goes numb.
You got it.
But AICA feeds more than just the facial highway, right? Because looking at the data, the symptom list just keeps going.
Right, because running right next to the trigeminal highway are the nerves for hearing and facial movement. So you also get ipsilateral deafness, meaning hearing loss on that same side, and ipsilateral facial paralysis.
Wow.
You also see this fascinating phenomenon called Horner syndrome, which involves a droopy eyelid and a constricted pupil on that side because the sympathetic nervous system wires traveling down from the brain are completely severed.
Okay.
And then, interestingly, you get contralateral, meaning on the opposite side of the body loss of pain and temperature sensation.
Now, we will definitely come back to that weird opposite side body numbness because, frankly, it is the key to this whole map.
It really is.
But first, let's round out the cerebellum with the third artery, SCA, the superior cerebellar artery. If PCA is brute balance and AICA integrates the face and hearing, what exactly does SCA do?
So SCA is all about fine-tuning. It produces a dorsal cerebellar syndrome. The structural difference here is that SCA feeds the very top of the cerebellum, specifically a structure called the dentate nucleus.
The dentate nucleus.
Right. Just think of the dentate nucleus as the cerebellum's outgoing quality control department. It literally smooths out your voluntary movements before they even happen.
Okay, so if SCA is blocked and that quality control department shuts down, what does that actually look like in the patient? Because the clinical data mentions an intention tremor.
Yes. And the mechanism here is so crucial. This is not a resting tremor.
Like what you'd see in Parkinson's.
Exactly. In Parkinson's disease, the hand shakes while doing nothing. But an intention tremor means the hand is perfectly still at rest. However, the moment the patient tries to deliberately touch their nose, the hand just shakes wildly on the way there.
Oh, wow. Because it doesn't have that smoothing effect.
Right. Without the dentate nucleus smoothing the electrical signals, the voluntary movement just becomes incredibly erratic. So with an SCA block, you see that tremor, you see the ipsilateral Horner syndrome, and just like AICA, you get contralateral hearing loss and contralateral pain and temperature loss.
But far less vertigo.
Right, much less vertigo than with the other two arteries.
Okay, so we've mapped the three main power lines to the cerebellum. But now we are moving up the brainstem. We're leaving the cerebellum and moving up into the midbrain.
And honestly, this is the exact spot where even advanced medical students usually just throw their hands up in defeat.
Yeah, it is notoriously intimidating. And that is because the midbrain is packed full of syndromes that are all named after dead doctors. You know, eponyms.
The dreaded eponym.
Right. Weber syndrome, Benedict syndrome, Claude syndrome, Nothnagel syndrome. I mean, it just sounds like a random list of 19th century gentlemen you do not want to meet in a neurology ward.
Yeah, pretty much.
But the clinical data actually provides a brilliant cheat code to crack every single one of them.
Which is so helpful because what's fascinating here is that these aren't 5 completely different, unrelated diseases.
Right.
They're actually just minor variations of the exact same structural theme. You don't need to memorize 5 lists. You just need to understand how the wires are bundled together.
Exactly. So think of it like this. The secret code the anchor for all these midbrain syndromes, is an ipsilateral cranial nerve, the third palsy.
The oculomotor nerve.
Right, the oculomotor nerve. It controls most of your eye movements and keeps your eyelid open. So think of cranial nerve the third like the main trunk line of a massive fiber optic cable bundle running right through the midbrain. If you see a patient with a drooping eyelid, a dilated pupil, and an eye that just can't look up, down, or inward on one side, you know that main trunk line has been cut. An infarct just happened in the midbrain.
And here's where the slider concept comes in.
I love the slider concept.
It makes it so clear. The name of the syndrome simply depends on which neighboring microscopic fibers, the ones bundled next to that trunk line, were also sliced. The rule is, same nerve, different neighbor, different name.
That's brilliant. So imagine a microscopic cursor slowly moving across the midbrain, millimeter by millimeter. Let's look at the first neighbor.
Okay, so if the stroke hits cranial nerve the third and the neighboring structure called the corticospinal tract, the patient develops Weber syndrome.
And what exactly is the corticospinal tract?
Well, it tells you its route right in its name, corticospinal.
Oh, cortex of the spine.
Exactly. It's the primary motor highway running from the motor cortex, the thinking, commanding part of the brain, straight down to the spine. It carries the electrical signals for voluntary movement.
So if you slice that wire in the midbrain,
the signal just never reaches the body. The mechanical result is contralateral hemiplegia, just massive paralysis on the opposite side of the face, arm, and leg.
Okay, so eye palsy plus paralysis equals Weber syndrome. But what if we move our microscopic cursor just a tiny bit deeper, slightly more dorsal in the midbrain? A different neighbor gets hit, right?
Right. Move the slider a millimeter deeper, and instead of the corticospinal tract, the stroke hits cranial nerve the third plus the red nucleus.
Now, why is it called the red nucleus?
It's basically a cluster of neurons that is literally rich in iron. So it actually gives it this pinkish red hue under a microscope.
Oh, wow, that's wild.
Yeah. And its function is to coordinate muscle tone and limb positioning. So if you damage the red nucleus, you don't get total paralysis. Instead, you get a catastrophic failure of muscle tone coordination.
Which looks like what?
Contralateral involuntary movements. So a severe tremor or hemichoria, which are these violent, erratic dancing movements of the limbs.
Oh, man.
So that combination, the eye palsy plus the chorea, is Benedict syndrome.
Okay, so same broken eye nerve, but a tremor instead of paralysis, and suddenly it's Benedict, not Weber.
Exactly.
Let's move the slider even deeper.
So if the damage is even more dorsal, completely bypassing the red nucleus and hitting the cerebellar connections, you get Claude syndrome.
How's that different?
This looks similar, but with prominent cerebellar signs, like that severe lack of coordination we discussed earlier, but importantly, without the involuntary dancing movements of Benedict.
Got it. And if we keep moving the slider to the cerebellar peduncle,
you get Nothnagel syndrome. A peduncle is basically a massive stalk of nerve fibers acting as a bridge between the brainstem and the cerebellum.
Okay.
So you cut the oculomotor nerve in that bridge, and you get the eye palsy plus severe contralateral cerebellar ataxia, just total uncoordination on the opposite side.
Now, there's one more midbrain eponym that's kind of an outlier, right? Perino syndrome.
Yes, Perino is the outlier because the mechanism of injury is usually completely different. The data emphasizes that Perino is most often caused by a mass lesion, like a tumor growing in the pineal region, physically pressing down on the top of the midbrain.
Rather than a stroke cutting off blood flow. And the mechanical failure here is really specific.
Very specific. It involves an upward gaze palsy. The patient physically cannot force their eyes to look up. They also have convergence retraction nystagmus.
Which means?
Well, when they try to focus on something close to their face, their eyes literally jerk backward into the eye sockets.
Oh, wow. That sounds awful.
It's very striking. They also present with light near pupillary dissociation, meaning the pupils don't react normally to light and limb retraction, which just pulls the eyelids back. It is a classic pressure syndrome.
So we've successfully mapped the cerebellum and the midbrain. We've traced the fiber optic cables. But what happens if the main pipe feeding this entire region, the massive basilar artery, gets blocked at the very top?
Right.
Or, on the flip side, what happens if we go much lower down the brainstem into the medulla? Let's start at the top.
Okay, so a top of the basilar syndrome is usually caused by an embolic occlusion, meaning a blood clot breaks off from somewhere else, travels up the basilar artery, and just gets wedged at the very top of the rostral end.
Which has to be catastrophic.
It's a massive chaotic event. It starves the midbrain, the thalamus, and even parts of the temporal and occipital lobes.
And the symptoms here aren't just physical paralysis,
Yeah.
right? I mean, the patient's behavior changes completely.
Yeah, and that's because of the thalamus. The thalamus is basically the brain's grand central relay station for sensory information, and it plays a huge role in regulating consciousness and sleep.
Okay.
So when a clot destroys that relay station, you see bizarre behavioral features. The patient exhibits severe somnolence, meaning extreme, unshakable sleepiness.
And the data also specifically mentions something called peduncular hallucinosis,
Yeah.
which honestly sounds like a 1970s psychedelic rock band.
It really does.
But what is actually happening in the brain to cause that?
It's such a fascinating glitch. Because the sleep-wake regulatory centers in the thalamus and midbrain are damaged, the brain essentially starts dreaming while the patient is awake. Yeah. Peduncular hallucinosis involves incredibly vivid, colorful, deeply realistic visual hallucinations. The patient isn't psychotic, their brain's visual and dream circuits are just misfiring due to the structural damage.
That's wild.
You also see ocular findings like vertical gaze paralysis and Collier's sign.
And Collier's sign is?
That's a retraction of the eyelids that gives the patient this wide-eyed, really intensely staring appearance.
Okay, so that is the extreme top of the system, where things get strange and behavioral. What about the bottom? Let's drop down to the medulla.
Down in the medulla, we have two classic structural failures you really need to know. The most famous is the lateral medullary syndrome, universally known as Wallenberg syndrome.
Right, this is the hook we started the deep dive with.
Exactly. It's most often caused by a blockage in an intracranial vertebral artery or sometimes the PICI artery we discussed in the beginning.
Right, the 30-second exam, Pearl. If a patient comes in, you check the list. They have an ipsilateral Horner syndrome, so a droopy eyelid, constricted pupil. They have severe ataxia. They have weakness of the palate, pharynx, and vocal cords, meaning they can barely swallow or speak.
Right.
But then we hit that impossible sensory split. The face loses pain and temperature sensation on the same side as the injury, the ipsilateral side. But the body loses it on the completely opposite side, the contralateral side.
It's such a specific pattern.
It is. How does one tiny millimeter of stroke damage split the body down the middle like that?
It's all about how the body's wiring crosses over as it travels up to the brain. Just think of it like two different sets of highway overpasses.
Okay.
The sensory nerves from your face come into the brainstem and travel straight down for a bit on the exact same side they entered. But the sensory nerves from your body, like your arms and legs, have already crossed over to the opposite side much lower down, way down in the spinal cord, before they even reach the brainstem.
Oh, so they are traveling on opposite sides of the highway when they actually pass through the medulla.
Exactly. A single, precisely placed lesion in the lateral medulla hits the facial nerve tract before it has a chance to cross over. But it hits the body's nerve tract after it has already crossed over from the other side.
One microscopic hit, two completely different electrical pathways.
Exactly. It's the ultimate proof that structure dictates everything.
Which brings up a massive common mistake highlighted in our data. Clinicians often assume that if a patient comes in suddenly falling to the ground, so-called drop attacks, or experiencing isolated vertigo, it must automatically mean they're having a stroke in this posterior circulation.
Yes, and structurally, that is almost always a flawed assumption.
Really?
Yeah, because the brainstem is so incredibly packed with wires that it is almost mechanically impossible for a stroke to hit only the balance center without hitting anything else.
Ah, I see.
Isolated symptoms, like just vertigo on its own, usually point to an inner ear problem. True posterior circulation ischemia will almost always present with accompanying structural features, like the numbness, the eye palsies, or the swallowing issues. You have to look for the structural pattern, not just one symptom.
Got it. Which brings us to the other medullary syndrome, Dejerine syndrome.
Right, the medial medullary syndrome. It's less common than Wallenberg, but because the clot hits the middle of the medulla rather than the side, the damaged wires are different.
So what are the symptoms there?
You get ipsilateral tongue weakness because the nerve controlling the tongue exits right there. You get contralateral hemiparesis paralysis on the opposite side of the body, but crucially, it typically spares the face because the facial motor nerves are higher up.
Yeah.
And you get a contralateral loss of tactile, vibratory, and position sense.
Okay, so we've mapped the cerebellum, the midbrain, and the medulla. We've seen how pinpoint precise these neurological outages can be.
Very precise.
But now, we arrive at the absolute extremes of this anatomy. What the clinical data describes as one of the most genuinely feared outcomes in all of neurology. a chilling combination of structural failures known as locked-in syndrome.
It is a devastating condition. Locked-in syndrome is caused by bilateral ventral pontine lesions,
Meaning,
meaning a massive stroke destroys the front part of the pons, which sits right in the middle of the brainstem on both sides simultaneously.
and the physical reality of this damage is just staggering. The patient suffers from quadriplegia, which is total, absolute paralysis of all four limbs because the motor highways are severed on both sides.
Yes.
They have aphonia, meaning a complete inability to speak or make a sound, and they have horizontal gaze impairment, meaning they cannot move their eyes side to side. Every single outward horizontal motor function is gone.
But here is the terrifying mechanical twist of locked-in syndrome. The stroke only kills the ventral part of the pons, the front. The structures deeper inside, in the dorsal part of the brainstem, are spared.
And what do those deep structures do?
Well, they include the reticular formation, which is the electrical generator that basically controls wakefulness and consciousness.
Oh, man.
It also spares the dorsal supranuclear ocular pathways, which control vertical eye movement.
Meaning the patient's wakefulness, their ability to look up and down, and their ability to blink are perfectly 100% preserved.
Yes. The patient is entirely, fully awake and cognitively intact.
There's an early warning sign for this, right? A herald hemiparesis.
Right. In basilar occlusive disease, before the full bilateral stroke completes its blockage, a patient might temporarily show weakness on just one side of their body, a herald hemiparesis.
Like a warning light.
Exactly. It's a flickering warning light that can appear hours before the full picture sets in. Recognizing that mechanical stutter is critical because once the full bilateral damage happens, the pathways are permanently gone.
So what does this all mean? The data gives us a pattern of the day visual that I think perfectly captures everything we've talked about, and it is going to stick with me for a long time.
It's a powerful visual.
It really is. I want you, the listener, to really picture this. Picture a patient lying in a hospital bed. They are fully awake. Their eyes are tracking you vertically, looking up and down as you walk to the foot of the bed. They can blink on command to answer yes or no. But they are trapped completely inside total unyielding paralysis, unable to speak a single syllable or move a single limb horizontally. Full, vibrant human consciousness, entirely locked inside a motionless structural shell.
It is the starkest possible reminder of the anatomy we've been mapping out today, the absolute mechanical separation of the cognitive mind from the structural machinery of the brainstem.
It really is. And I think that brings us to the ultimate synthesis of this entire deep dive.
Right.
At the beginning, we talked about how this territory, the posterior circulation, seems like a chaotic tangle of terrifying medical words and dead doctors. But what this anatomical map actually reveals is a beautifully logical, albeit incredibly fragile, electrical grid.
Exactly. Every single symptom we discussed today, from a sudden tremor in the arm to a dilated pupil to a loss of temperature sensation precisely splitting the face and the body, it's not a random occurrence.
Not at all.
It points directly to an exact microscopic coordinate on that map. When you know the wires, you know the outcome.
So the next time you casually blink or just look up at the ceiling, I want you to take a second to appreciate it. Really appreciate the perfectly intact microscopic wiring running through your pons and your midbrain that makes that incredibly simple, everyday movement possible. Because as we've learned today, those tiny, fragile cables carry the entire weight of your interaction with the physical world.
I'll leave you with one final thought to mull over, building entirely on the sheer mechanics of the anatomy we've mapped today.
Okay.
If a microscopic stroke in the ventral pons can perfectly trap a fully conscious, aware human mind, stripping away absolutely all physical ability to interact with the world while leaving the intellect, the memories, and the internal monologue completely untouched.
Yeah.
Where exactly does the mind end and the machinery of the body begin?